Welcome to our video on neurological disease. Let's begin. In this lecture, we will discuss cerebral palsy and infantile hypotonia. Let's start with cerebral palsy. Here's a list of topics we'll be discussing for cerebral palsy, and let's start with the definition. Cerebral palsy is a heterogeneous group of non-hereditary and non-progressive disorders that involve permanent motor dysfunction, including abnormal tone, posture, and/or movement. The exact etiology is unknown, but cerebral palsy is most commonly associated with prenatal and perinatal insults to the brain. Cerebral palsy can be caused by any factor that compromises cerebral blood flow, oxygen delivery, and/or proper development of the fetal nervous system. Examples include prematurity, which is associated with conditions such as intraventricular hemorrhage and periventricular leukomalacia. Periventricular leukomalacia is a type of injury to the white matter of the brain of a premature infant where necrosis to brain tissue occurs. Other risk factors include intrauterine growth restriction, perinatal hypoxic ischemic injury, intrauterine infections such as Torch's infections, trauma, and tobacco and alcohol use. Cerebral palsy can be subclassified into different types, which include spastic and non-spastic types. The non-spastic type is further classified into dyskinetic and ataxic subtypes. In fact, the most common presenting type of cerebral palsy is the spastic one. Spasticity is a term used to describe stiffened or tightened muscles. Therefore, patients with spastic cerebral palsy have restricted movement where their muscles remain contracted. The presentation can be variable and depends on the number of limbs affected. Patients can present with spastic diplegia, hemiplegia, and quadriplegia. Spasticity that leads to toe walking, hyperreflexia, evident by increased deep tendon reflexes on physical exam, and positive Babinski sign are characteristic of spastic cerebral palsy. Let's remember that positive Babinski sign is the fanning of the toes upon stimulation of the plantar foot. Toe walking specifically occurs due to the involvement of the flexor muscles in the calves. This causes the heels to become raised and pushes the toes downward, causing the child to walk on their toes. Also, because of spasticity, patients may develop equinovarus deformity of the foot. Here's an image showing equinovarus deformity. This deformity describes feet that are pointing down and inwards. In cerebral palsy patients, it occurs due to the hypertonia and hyperreflexia that affect the lower limbs. Let's now discuss the non-spastic type of cerebral palsy. Patients with dyskinetic subtype present with involuntary movements such as dystonia, athetosis, and chorea. Dystonia is the involuntary sustained muscle contraction. Athetosis consists of slow, writhing movements, and chorea consists of rapid and irregular dance-like movements. Finally, cerebral palsy can also rarely present with ataxia or lack of coordination. Even though cerebral palsy can present differently depending on the subtype, delayed achievement of motor milestones is usually the first and most common sign. Gait abnormalities such as toe walking and scissoring of the legs are commonly observed. These occur due to the increased spasticity of the lower limb. We will be describing this finding in more detail in a moment. Another common gait is the commando crawl. This is a phenomenon used to describe when a child is pulling themselves with their arms while dragging their legs behind them, and occurs due to contractures of the lower extremities. Other symptoms such as joint contractures, intellectual disability, swallowing difficulties, drooling, and abnormal speech may also be present. It is important to note that even though the intellectual disability can be present in a portion of children with cerebral palsy, many patients have normal intelligence. Other comorbidities associated with cerebral palsy include epilepsy, scoliosis, and strabismus. Let's take a look at this image from neuroanatomy. In cerebral palsy, the cerebromotor pathways are damaged, such as the corticospinal tract that is outlined here, and this, therefore, is what leads to the motor dysfunction that is present in cerebral palsy. Here's an image of a child with spastic cerebral palsy. Notice the position of the lower extremities. This appearance is called scissoring because the stiffened legs cross and look like scissors. It occurs due to hips that are flexed and adducted, knees flexed with valgus, and ankles in equinus, resulting in toe walking. Knee valgus is a deformity used to describe when bones at the knee joint are angled downward away from the midline, resulting in lower extremities looking like this. Equinus is a foot deformity used to describe a foot that is in plantar flexion due to the inability to dorsiflex the foot. This is also the underlying mechanism behind toe walking. The arms of this child are also spastic and flexed. Cerebral palsy is mainly a clinical diagnosis. Imaging with cranial ultrasound or a brain MRI can identify structural causes such as intraventricular hemorrhage, periventricular leukomalacia, or other structural abnormalities. Periventricular leukomalacia is characterized by symmetrical periventricular focal necrosis and cystic formation, as well as diffuse white matter injury in the brain of a premature infant. Let's take a look at this MRI image of a patient diagnosed with periventricular leukomalacia. We can notice the cystic formation next to the posterior horn of lateral ventricle. Here's an MRI image showing an intracerebral hemorrhage. If identified on a brain MRI in a child with cerebral palsy, can possibly be the underlying cause. Here's a CT scan of the brain showing hemorrhage in lateral and third ventricles. Recall that intraventricular hemorrhage in premature neonates originates from a highly vascularized area called the germinal matrix within the brain. Intraventricular hemorrhage is a common comorbidity in premature neonates, and prematurity is an established risk factor of cerebral palsy. There is no cure for cerebral palsy. The management includes a multidisciplinary approach. Special education may be needed to address individual child's needs. This includes addressing the child's mental development. Physical therapy helps to maximize the functionality of the child. Antispastic medications such as baclofen, pumps, and botulinum toxin can be used as well. Recall that botulinum toxin, or Botox, is a neuromuscular blocking agent that relaxes muscles by inhibiting the release of acetylcholine from presynaptic channels. Surgical release of contractures can also be considered. As a prevention, magnesium sulfate can be given to mothers at risk of premature delivery for fetal neuroprotection. Let's do a review question. An 18-month-old girl is brought to the physician by her mother due to the patient's inability to walk normally. The physical exam reveals toe walking and scissoring of the legs. Deep tendon reflexes are hyperreactive and Babinski reflex is positive bilaterally. She was born at 33 weeks of gestation due to preterm labor rupture of membranes. What is the optimal management of this patient's condition? This 18-month-old girl presents with toe walking and scissoring of the legs. This finding indicates hypotonia in the lower extremities. Deep tendon reflexes are hyperactive and Babinski reflex is positive bilaterally. These clues suggest the upper motor neuron damage. Given all these findings and the fact that she was born preterm at 33 weeks of gestation, she likely has the spastic cerebral palsy. The optimal management of cerebral palsy is a multidisciplinary approach involving special education, physical therapy, and antispastic medications and surgery for contractures. All right, let's next discuss infantile hypotonia. Here's a list of topics we'll discuss for infantile hypotonia. Let's start with the definition. Hypotonia is defined as decreased muscle tone. Hypotonia and weakness in early infancy can be a sign of a central nervous system, a primary neuromuscular, or genetic disorder. There are several conditions that can present as hypotonia in infancy. It is a feature of numerous genetic syndromes such as Down syndrome and Prader-Willi syndrome. Inborn errors of metabolism such as glycogen storage diseases, Tay-Sachs disease, and others can also present with hypotonia. Infections such as botulinism due to ingestion of honey can cause generalized hypotonia, also caused floppy baby syndrome. Neuromuscular disorders such as spinal muscular atrophy and myotonic dystrophy can cause infantile hypotonia as well. Finally, endocrine abnormalities such as congenital hypothyroidism and hypoglycemia also present with hypotonia in infancy. A 6-month-old boy is brought to the physician by his parents due to increased sleepiness and weakness. The infant has a weak cry. His mother states giving him honey products recently to grow healthier. The physical exam reveals a lethargic infant and hypotonic extremities and a 1+ reflex. What is the most likely diagnosis in this patient? The infant presents with increased sleepiness and weakness. The physical exam reveals a lethargic infant with hypotonic extremities and 1+ reflexes. Given that the mother gives him honey, he likely has an infantile botulinism. This is because the Clostridium botulinum spores are ingested with honey and germinate in the gastrointestinal tract. Botulinism typically causes a descending paralysis with hypotonia and hyporeflexia. Because infantile hypotonia is a feature of many different disease etiologies, a combination of the patient's history, physical exam, and a thorough investigation is needed to identify the cause. Obstetric and perinatal history can provide important information of potential insults such as infections and perinatal hypoxia. Assessment of the infant's general appearance, including identifying dysmorphic features and congenital defects, can be very useful to aid with the diagnosis. The hypotonic infant lies supine in a frog-like position, and spontaneous activity is decreased as well as the muscle tone. A complete neurological exam should also be performed to assess the etiology and extent of hypotonia and weakness. Management of infants with hypotonia depends on the etiology, and therefore it's essential to identify the cause to be able to treat it. All right, now let's solve this question. A 12-month-old boy is brought to the physician due to failure to reach developmental milestones. He has not learned to sit or crawl. He babbles but does not make concrete sounds. He also has feeding problems and often chokes during feeding. His elbows and knees are flexed. Physical exam reveals spasticity and increased tone in the upper and lower extremities. He also has slight strabismus. An MRI of the brain reveals periventricular leukomalacia. Which of the following is the most important risk factor for the development of this condition? A. Congenital CMV infection. B. Congenital toxoplasmosis infection. C. Maternal alcohol during pregnancy. Or D. Premature birth. Okay, so this 12-month-old boy is brought in because he wasn't reaching his developmental milestones. He has upper motor neuron signs such as spasticity and increased tone, feeding problems, developmental delays, as he has still not learned to sit or crawl, and abnormal speech, as he babbles but does not make concrete sounds. Babies should be able to sit unsupported by the age of 7 to 9 months and start to crawl by age of 9 months. So this is concerning in a child who is 12 months old. By the age of 12 months, babies should be able to say a few words like mama and dada distinctively. So this baby's inability to say any distinctive sound is concerning. Furthermore, brain MRI reveals periventricular leukomalacia, which is frequently present in patients with cerebral palsy. All these features make spastic cerebral palsy the most likely diagnosis. The most important risk factors for developing cerebral palsy are premature birth and low birth weight. This makes option D, premature birth, the correct answer. Recall that cerebral palsy commonly presents with delayed achievement of motor milestones. Gait abnormalities are common, and patients may have swallowing difficulties, drooling, and abnormal speech, just like we saw in our patient. Children may also have associated comorbidities such as epilepsy, scoliosis, and strabismus. Now let's see why other options are incorrect. Option A, congenital CMV infection, is incorrect because although it increases the risk of CP, a brain MRI would show periventricular calcifications, not periventricular leukomalacia. Furthermore, features of congenital CMV infection such as skin rash, seizures, and microcephaly are absent in this patient. Option B, congenital toxoplasmosis infection, is incorrect because although it increases the risk of CP, a brain MRI would show intracranial calcifications instead. Also, features of congenital toxoplasmosis infection such as microcephaly, hydrocephalus, and chorioretinitis are all absent in this patient. And finally, option C is incorrect because although maternal alcohol during pregnancy increases the risk of CP, features of fetal alcohol syndrome such as small head, short nose, and thin upper lip are absent in this patient. This makes D, premature birth, the correct answer. On step 2, vague questions like this can show up where you may be given a list of risk factors and be expected to identify the single most important risk factor for a particular condition. And this concludes this section.